Hello, I'm Nancy Rowe from Rush University Medical Center and editor of C.L.D., Clinical Liver Disease, which is the A.A.S.L.D. multimedia journal. I'm delighted to be joined by Dr. Lynn Taylor today, who is from the University of Rhode Island, Kodak Behavioral Health, and I want to alert everyone that she is one of the many excellent lecturers from the 2019 A.A.S.L.D. Hepatitis C Special Interest Group, or SIG program. Thank you so much, Lynn, for joining me.
Thank you, Nancy. It's wonderful to be here today.
So, Lynn, I want you to tell me a little bit about where you work and what you do.
So, Nancy, thanks for the opportunity to talk with you today. So, I spend most of my time at Rhode Island's only nonprofit methadone maintenance program, providing on-site care for people with and at risk for hepatitis C, hepatitis B, HIV, and other infectious consequences of addiction. What we do at Kodak and in this model that's a little different than what is sometimes the approach in hepatology is that we focus on incremental care. Very slow, steady relationships with patients over many years so that we're thinking about preventing hepatitis C, evaluating hepatitis C, curing hepatitis C, caring for cirrhosis, but doing this and caring for people over the long term.
So your clinic is something that we would describe as a co-located clinic, correct? So what does that even mean?
So really it seems like in the Hep C epidemic, the biggest infectious disease killer in the United States, driven by injection drug use and the US opioid crisis, there are really going to be only two approaches at the population level to getting people treated and cured. When we focus on people who inject drugs, again, the population overly burdened by Hep C and driving the epidemic, either we have to navigate a very large number of people into care, typically in the US, subspecialty, tertiary, conventional health care, or we're going to have to say, where can people access care? Where are people already able to engage? Where is a low threshold, welcoming, less stigmatized environment, easy to navigate for people who are struggling with the chronic, preventable, and treatable disease of addiction. So what's been seen in the literature, we have a very impressive body of literature from the United States, from many nations around the world, is that co-located care can unite care for addiction and hepatitis C under one roof, give us one-stop shopping, and really allow us to amplify the care, bring Hep C care to a larger segment of the population.
So you said some pretty important things, and that was care that's non-stigmatizing and sensitive to the individual's need. Why can't a patient struggling with addiction make it to my university where I can help give them the standard of care that I see as the current model?
Well, some do. Again, if we were talking about small numbers of patients, that would be fine. But we have to realize, again, we're talking tens of thousands, hundreds of thousands, globally, millions of people. When you think about standard subspecialty care, here's how it usually goes. Someone's given an initial appointment maybe 3 months from now. Maybe someone struggling with substance use disorder makes that appointment 3 months from now. Likely not. If the person misses the first appointment, there's not often someone to find that person and re-engage and give the person a second appointment. If we make that first appointment, what happens? Often there's a lot of focus on what are you doing? What's going on with your substance use? How did you catch Hep C? A lot of shaming. Again, this is not something that people aspire to. This is a difficult, very common chronic illness that's treatable. People make it to that first visit. Usually blood gets drawn, people are told, let's bump you off the cascade to care, go get a scan somewhere. And then the second visit's a few months later. Maybe you see a different hepatology fellow. And the process is protracted. Time is passing. Now, people who inject drugs now have viremia, virus in the blood over time. Now there's risk of transmission. That's what we're seeing in the United States. We're having our incidence skyrocket with the opioid crisis. So what we do with co-located care is to streamline and accelerate the process of Hep C care. And so, for example, what we do at our program is as people enter care for opioid use disorder, everyone universally, with the opportunity to opt out, nothing's coercive, everybody gets blood tests. one draw for hepatitis C, reflexive to viral load and genotype, Hep B panel, HIV, the blood that we need for APRI and FIB4, because we start with non-invasive biological serum markers rather than having to send people off-site for scans, especially when we have a population of young people with young Hep C infections. They didn't have Hep C last year, they did have Hep C this year. To have everybody go get elastography means we're not going to be taking a lot of care, and we're spending a lot of taxpayer Medicaid and Medicare dollars probably. So by the time people enter care for their opioid use disorder, they already have had the labs. The nurse, my nurse partner, Sophie, navigates people into the first appointment, and sometimes that happens, sometimes people miss that appointment, and people know that if they miss 100 visits, they show up on day 101, we're so glad to see them. We're not enabling people, we're not encouraging people not to be responsible adults, but what we have to understand is often with substance use disorder, opioid use disorder, polysubstance use, people are really struggling, their brain's been hijacked, they're not really always able to participate in keeping appointments, making appointments. I've never, ever, ever in 20 years of taking care of vulnerable and stigmatized patient populations had a patient who doesn't want to make appointments. But if we make it easy to come in, we just say, you know what, we understand, we care, we're here. When people come in, we say, we're glad to see you. The first visit, we do a full evaluation, which means for me as a generalist, as a general internal medicine physician, I really rely on A.S.L.D. Of course, I'm not a hepatologist, but I joined A.S.L.D. many years ago and appreciate being welcomed in to learn as much hepatology as I can, knowing I haven't had the fellowship, because referring my patients to hepatology care at the population level doesn't work. So we do as much as we can. We assess liver disease, comorbidities, Hep B, HIV, and we let people know, you know what? Something's going to happen. We're going to order your meds today. After the first visit, by the end of the first visit, we're ordering your direct-acting antiviral agents, and as soon as we can get them approved by your payer, we're going to start. Second visit, it can be a week later. If patients don't show up, whenever they show up, we're ready. Will be Hep C treatment initiation. Everybody loves Hep C treatment. When you're taking care of people in a setting where everyone's struggling with opioid use disorder, everyone has Hep C, everyone knows a friend who had Hep C, everyone had a parent, a loved one who died of end-stage liver disease. There's no such thing as are people willing. It's the easiest thing to get treated and cured. Addiction's the hard part. People feel so good. We have wonderful data, very strong data from patient outcomes research showing that people feel so much better with treatment physically, psychologically, and it's very important with this population, we're also treating for the prevention benefit. We're now treating an individual, but that means an individual struggling with injection drug use is not transmitting Hep C to injecting partners. And also in a co-located model, what we learn is it can be very helpful. Bring your friends in, bring your partners in, anybody that you might be using drugs with.
So you made it seem like you were a little inferior because you were a generalist and you have an association with A.S.L.D. I think that from someone who's a hepatologist, but no longer a generalist, and certainly not at all an addiction management specialist, that you are actually much more equipped to address the population that I'm somewhat tasked to work towards elimination on. And that, I mean, I think that we try to give non-stigmatized care in our clinic. Many of us are capable of that, but the clinic cannot necessarily support the system and cannot offer often addiction medicine, which is one of the best and most important messages of co-located clinic, that it's the addiction struggle that, you know, is equally, if not more important than the hepatitis C. And I suspect you might also do a little bit with risk reduction that we probably do not do.
We do a lot with risk reduction, and the World Health Organization has tasked us with Hep C elimination. We will never meet elimination goals with direct-acting antiviral agents alone. Good drugs, we've heard, are not enough. We must have treatment for opioid use disorder and other types of addiction. Unfortunately, we don't have pharmacotherapies yet for stimulants and benzodiazepines and optimal therapies for alcohol use disorders, but we do have very effective medications and vast global experience for years showing efficacy, prevention and treatment benefits for opioid use disorder and economic benefits. And so we know that we must, according to the WHO, to eliminate Hep C, we not only need DAAs, but we need to expand access to opioid agonist therapies. These are the best treatments that we have for opiate use disorder. Up to 80% of people globally who inject drugs do inject opioids. Opioid agonist therapies decrease overdose-related deaths. Again, overdose-related deaths skyrocketing in the US and are feeding our transplant programs. I tell my patients every day, I do not want you to be an organ donor. The organ donors in this country now, we're getting a new crop called overdose death donors, mostly less than 40 people who are dying of overdose. It's a tragedy, and I care about liver transplant, and we want someone who needs a heart to get one, but we need to put more effort to prevention. So by the way, I have in my bag my naloxone. I carry it everywhere to be able to respond in case somebody overdoses with opiates. We should all carry naloxone. Everybody should, everywhere. And we could save a life. Massachusetts, a lot of overdose, even though it's a wonderful healthcare system. It's just very prevalent problems in the US right now. So we need opioid agonist therapy. And we need access to sterile injecting equipment. The WHO, World Health Organization, has tasked us with making sure that people struggling with the treatable disease of addiction who are injecting drugs have access to a brand new needle with each injection. So we work with people to say, yes, it's best for your health not to inject drugs, but it's not a panacea, it's not a magic pill. Maybe DAAs are magic pills, but opiate agonist therapy treatment helps with addiction, but it's not going to make it go away, as we can eliminate the virus. For the first time ever, we can cure a virus with pills. We need to make sure that everyone who's injecting has access to a brand new needle with each injection. And so the WHO says part of our global Hep C elimination plan must be to make sure that we increase access to needle syringe programs, sterile syringe access. So this is really, in the absence of a vaccine, what our mandate is: access to opiate agonist therapy at methadone clinics, such as we have in the United States, and then to create a system where we have more diverse access to methadone and buprenorphine, as we see in many other nations: Portugal, Switzerland, Iceland, Australia, leading the way in terms of elimination and targeted, tailored programs for people who inject drugs. So really, without a vaccine, we need these three components of care: opioid agonist therapy expansion of access to sterile injecting equipment, and access to DAAs, through probably, as a primary goal, colocated care for people who inject drugs.
Well, Lynn, I really want to thank you. You are an incredibly passionate individual for what I would say we need more of you. Although there are many reasons to think that we might need more hepatologists, we absolutely need more individuals willing to work with these vulnerable populations in an environment that they can get effective and holistic care, not just hepatitis C therapy in an academic environment. So I want to applaud you for the efforts and hope that this, maybe this one conversation will motivate someone to go out and replicate some of your excellent work.
Well, the work that I do is really just replicating the excellent work of people, Diana Silvestri, who I met at A.S.L.D., Norbert Broy, people all over the world who are A.S.L.D. members, and just looking at the literature and the evidence and following best evidence-based practices. So I'm grateful to A.S.L.D., and I'm the most fortunate physician in the world to get to take care of such a wonderful, worthy population of people trying so hard to improve their health and care for others.
Well, thank you.
Thank you.
I do want to remind the viewers that this is one of many of the lectures from the A.S.L.D. 2019 Hepatitis C SIG program. And if you'd like to see the same program, the whole program, it will be on the site.